ladies and gentlemen. It's a difficult task to speak after the stalwart. I'll try to do as much justice. So we know that most of our patients in our country, when they start on chronic dialysis, they get an acute non-cuffed catheter. Long-term access could be a fistula or a tunnel dialysis catheter because grafts are as such very few in Indian context. And it has always been a conundrum. We do hate the catheters, but we can't live without them. So catheter is a reality, though in ideal world, we would expect all our patients to have functioning long-term AV fistula. If we present our data, we have been using most of the time tunneled cuff catheter to begin with, because most of the patients, even in tertiary care center, present very late. There are only 10% of patients who have a fistula in place before they start on their dialysis. The use of non-cuffed acute catheter is 10% only. But we are getting elderly population, diabetic patients. So at the end of 90 days, which is like a cutoff before we go on to have a matured fistula, only 60% of the fistulas mature and 40% of the patients are still left on catheter beyond 90 days. What are the options? Ideally, right internal jugular vein is to be preferred, followed by left internal jugular vein, external jugular vein as we presented yesterday, use of femoral veins, subclavian as a last resort, and in rare cases, translumbar and transhepatic accesses can be considered. Now, why do we prefer right internal jugular vein over a left internal jugular vein? Because right IJV has less amount of complications. If you try to puncture on the left side, the dome of the left lung is higher than the right, thoracic duct empties on the left side, and there is a straight course to the superior vena cava on the right side, and because of these reasons, our right IJV is preferred over left IJV. And there could be various other issues because patients have finite options for vascular access. And there could be quite a few patients who would be left with no choice but to be on tunneled cuff catheter for a long-term basis. So we started seeing these sort of problems when we had patients who had this sort of multiple level of stenosis. And in those days, this is quite a few years back, we started putting translumbar catheter, which we had found as a new modality. And I used to always discuss this with my mentor, Dr. Tushar Vacharajani, the previous speaker, till one day he told me that always start from the distal end. So after doing about 10 translumbar catheters, we moved on to transfemoral long catheters with trying to position the tip right up to the right atrium. So we did initially translumbars, then we came to transfemorals, then we came to external jugular veins, and as we advanced, our own knowledge, our own expertise improved, and then I'll now present the difficult situations where we have done this tunnel catheters. So this is the story of a 46-year-old female whose obese, has short neck. She's been on dialysis for 6 months, but has had 8 admissions at another center for vascular access. She has had failed AV fistula, failed graft, 4 cuffed tunnel catheters, 2 failed in the right IJV, which was inserted by vascular surgeon, 1 failed in the left subclavian vein, replaced by another, both inserted by a cardiovascular surgeon. And now she is referred by the treating nephrologist to me that do something, this female is not doing vein. Now this is what happened. The first catheter was inserted like this without a fluoroscopic guidance. It's awfully in a bad position, and obviously you don't expect this to work. But then this was replaced by another catheter. If you see it on the left hand side panel, the right IJV is still in the wrong position. So the patient went to another surgeon and he puts another one, and then see what has happened. The tip has got kinked. Probably it has got into the azygous vein. So obviously these catheters are not going to work. So when she came to us, we decided that we must have a proper vascular mapping, and we did a MR venogram. These are the images which one could obtain without injection of a contrast medium, and this is the clarity. But again, we were not very sure whether we are going to be in the right position because this was a doubtful area. So we decided to go ahead. On sonography, the EJV was dilated because the IJV was thrombosed. We punctured it under sonography guidance, made an injection, made sure EJV was patent, and we put a catheter, and this is the final position. This position is slightly different from, because you see this IJV would have come somewhere there, but this is in a different course, and this is where your right brachiocephalic vein comes before it enters into the SVC, and that's why this shape is seen. Now this EJV can be used also for inserting acute catheters, as we did in this case, who came up for a dialysis and a puncture on the right IJV was not possible. We immediately shifted the patient to the fluoroscopy suite and found that EJV was patent and IJV was blocked. We put in a temporary catheter to tide over the crisis, and after giving 3 days of dialysis, we decided to change it to a tunnel catheter. So this was the final image when we inserted the EJV catheter, and we thought it's over. Took up for dialysis, next day, no flow. Took an X-ray, the catheter had spontaneously developed this kink. Took him back to the operation theater, dissected the neck, created the space there, got the curve in proper position, and things were again all right. This was again the final result. What happens when we put the femoral catheters? This is what happens if we use the conventional 19 or 23 centimeter length catheters, which will probably not even go up to the common iliac vein. And then you will end. So this was a female who came with multiple levels of central venous stenosis. She had a short segment stenosis earlier to begin with. We put a transfemoral catheter and we thought the problem is over. Till she came back about a year later, the catheter had got cracked. So somebody decided to remove it, tried to insert the catheter, but he ended up putting this catheter. So this time again we said we'll first evaluate the veins, and this was a long segment catheter, and it was probably going to be technically difficult to do a plasty of this long segment. But by then, as I said, we had evolved, and this time we put an external jugular catheter in this patient, and then patient did well. There could be other problems of malposition. So this was a catheter inserted. The tip appears to be little low because usually one would try to pull back and give a proper position, but in this case what happened was everything went on well. It was done under sonography guidance, it was under fluoroscopy control. When we put it in, no backflow. We would inject the dye, it would get washed away, but every time it would get washed away, patient would complain of pain in the right lower chest. We were wondering what's happened, but we knew for sure that this catheter is not in proper position. We abandoned the procedure. Luckily, patient was hemodynamically stable. Next day got a CT scan done. The catheter, which appeared to be okay, had actually migrated into the posterior mediastinum, causing little bit of pleural effusion. Patient was hemodynamically stable. We decided to see if we can salvage this catheter. Took him back to the cath lab, made a fresh puncture quite higher up, just below the pinna, enter into the SVC, made sure that we were in the SVC. Taking that guide wire as a guide, now made a lower puncture, again ensured that we were in the SVC, pulled this catheter back from this position, gave a pressure here to make sure that there is no pneumothorax, no air entering inside, and then over a lower guide wire which we had inserted freshly, and we just slipped back the catheter and the catheter functioned well. What do you do in such a situation? So this is EJV puncture and this is the long segment of stenosis. This is where you require a lot of patience and perseverance. This patient again had multiple failed fistulas, a diabetic patient. So we decided to see if we can bridge this gap. And these are all the collaterals. And as I said, now we are preferring more of going through these collateral veins rather than going through the inferior vena cava approach. So we decided to see if we can cross this. So we come up to here, the bridge is still there. We used a long Chiba needle, ultimately taking multiple views, AP and lateral, AP and lateral. Ultimately, we ensured that we had crossed this bridge. This requires a lot of guts, a lot of time, a lot of patience. Ultimately, once we had this access covered, then it was just easy, dilated this tract, put a pump cath and came out. This is another very interesting case, a 55-year-old lady who was initiated on dialysis for 6 months and had developed increasing breathlessness. Being a diabetic, and she was to be considered for a transplant, so she was thought to have cardiac issues. So she was referred from another hospital to our cardiologist, who just informed me that give a cover dialysis after the angiography, patient will go back next day. And when I saw her, they told me that she is getting breathless on dialysis, and when we try to remove the fluid, she is going into hypotension. So what to do? So moment I saw her, I said, look, stop this dialysis. She is not in fluid overload. The problem is of another kind. Called up the cardiologist. I said, this is the problem of the catheter, and this is not a because apparently the coronary angiography was normal. So this was the catheter. Now, there were two problems why this catheter would not, this was not giving proper flow also, because the tip was very high and probably there was a kink at this position. So this catheter was anyway not going to function. So next day we got and this was the reason I said this is a central venous stenosis, because there were such dilated veins over her anterior chest wall. So a CT was done, and you can see nice thrombus sitting around the tip of the catheter. So this is obviously not going to work. And the problem was not only acute. You see this acute thrombus around the tip of the catheter, but you see so many collateral veins, what were seen clinically also. So that means there is a chronic stenosis, and on top of that, acute thrombus has occurred, and that's why this patient is going into this problem. And this was the reason, SVC stenosis, and that's why she was getting breathless, and moment you try to remove the fluid, she was going into hypotension. So we did a thrombosuction, make sure the IJV had become patent, but when we did that, we found that this was the stenosis. So just at the tip, because the tip was high placed, almost in the junction of the SVC to RA, the tip had caused stenosis, and that was the reason the thrombus had occurred. So after ensuring that IJV was patent, keeping the catheter still in the position, we did the angioplasty. You see a nice wasting here suggestive of this, corresponding to this level of stenosis. This was dilated completely, and once that was done, a new catheter was inserted with tip placed in the middle of the RA, and then the patient did fine. Coming similar to what Dr. Tushar mentioned in the previous talk, why is this catheter not working? There are two problems here. We injected the dye, we see this shadow, and that's also obviously the fibrin sheath. But you see this negative filling defect. This patient also has a clot sitting there. We pull back the catheter, take the picture. This is the fibrin sheath. So we did the balloonplasty, and the vein was open. And then we made all the attempts, same as what Dr. Gaurav presented yesterday. We could not remove the clot. It was firmly adherent to the wall. So we decided to take a palindrome catheter which has a spiral Z tip, and tried to go beyond the catheter almost to the junction of RA and IVC, and this catheter worked. And we have been talking about non-cuffed catheters causing central venous stenosis. What do you think? Central tunnel cuff catheters cannot cause central venous stenosis? Obviously, they are also known to cause. So this is a 51-year-old female, 5 years of tunnel cuff catheter, which ultimately was removed for some wrong indication. So now she was subjected to a fistula, and then a left IJV catheter was inserted, and after 2-3 weeks this catheter was malfunctioning. So when we took her up, the tip was here. This is obviously going to cause, but then what had happened was, we decided to put a guide wire, and it would not go in because it was going into this blind segment. This was either a thrombus or a venous dissection. We could not make out. And so we made a new, and then we also realized that the original catheter was inserted such a high level on the left side. So that's why the length had fallen short. And this was the new catheter which we placed subsequently, but to overcome that, we had to make a new puncture and negotiate the guide wire into this patent segment, because otherwise this guide wire was going into this blind segment only. So we managed that, put the catheter, we thought everything is over, referred her back to the referring unit. And this was what I mentioned. She came back because there was a crack at the tip of the catheter. So we have to take her back again. But this time, knowing what had happened previously, so this is the pullback of the catheter, and the full left brachiocephalic vein is stenosed. So this time we decided to do a plasty. It was such a tight lesion that even with high pressure balloon ruptured. But anyway, we managed to pull back the balloon and inserted a fresh catheter, which is now working beyond 2.5 years. So we have multiple access options. We have IJV, we have EJV, we have femoral, we have subclavian. Now in such situations where there are multiple level of thrombosis, we have started going into the collateral veins, and translumbar and hepatic should be as the last resort. If we look at the thrombosis rate and infection rate, right IJV and IVC, there is not much of a difference either in terms of thrombosis, or not very major difference, which one would expect that IVC catheters through femoral would be more prone to infection. So, ladies and gentlemen, I would like to end by saying that necessity is mother of invention, and dialysis vascular access is ever-changing concept, and we should be proactive so as to give best lifeline for our dialysis patient. Thank you very much.
Hemant, that was really an excellent presentation. Very innovative and thought-provoking innovations, as you would all agree. Before I open the discussion to the House, one question for you, Hemant. How about going in for, have you ever tried a transthoracic superior vena cava catheter insertion directly into the SVC where everything else has failed? That's one, if you're using translumbar and all those approaches. And secondly, have you ever thought of using the collaterals? I mean, can we really go in and put just in case we can put the guide wire, negotiate it well and be confident and use the collaterals? So these are the two things. When we have exhausted everything else you said, directly into the SVC?
Yeah, so the second question, yes, we have started using these collaterals. The problem is you can't leave the catheter tip in the collateral. We'll have to still go into the RA. And crossing that bridge is a difficult task. Sometimes the guide wire goes in and then you just do a plasty, create a passage. Because this collateral probably will not be adequate enough to accommodate your 11 or 12 French dialysis catheter. So we need to dilate it. So and we have not attempted direct puncture of the SVC, transthoracic, no. That is something which is described, but we have not attempted.
Dr. Mukherjee?
Dr. Mehta, excellent talk. I just wanted to know, how do you approach the translumbar? How do you go about it?
Okay. You make the patient in the prone position. It's done from the left side. You mark the iliac crest, try to localize the topmost position of the iliac crest. Usually 2 finger above that, about a centimeter, 2 centimeter, is your puncture site. Under fluoroscopy guidance, you direct your needle on the spine at the level of L2 to L3. That is where you would expect your IVC to lie. Once you go there, there is a long needle available, puncture needle, which comes with the set. And once you go in, keep on aspirating till you hit the IVC.
You get a separate set for this
Yes.
translumbar?
Yes. Usually for Indian patient, you would require total length 55 centimeter catheter. See, the conventional catheters which are available are 36 centimeter,
Correct. And
which
40.
has the insertion length of
Yeah.
19 centimeter, or 40 centimeter,
Yeah.
which has the insertion length of 23. Then you have 45 centimeter, which has insertion length of 28. These are the special ones will have to be brought in, which are available in Indian market,
Okay.
but rarely. This total length is 55 centimeter.
centimeter.
Yeah, that's what will probably go right up to the RA. Because one thing has to be remembered, if you are using IVC as a tunnel catheter, at least try and place your tip suprarenal. Anything infrarenally placed is likely to lead to more thrombosis. You try to go as high as possible, and if you can go into the RA, that's the best.
Dr. Malik, please. Dr. Malik.
About the femoral vein catheters, we have experience about internal jugular or external jugular, and we can go for a few weeks. But what about the, I'm not saying the cuffed catheters. What about the femoral vein catheters? For how long can we go? Because I have the experience, we were using these femoral vein catheters in certain difficult situations. We could go after 2-3 weeks ordinary, non-cuffed catheters and sending them home also. What would be your guide? Because there are no guidelines about femoral vein catheters.
I would say 7 to 10 days is maximum we should do. See, all these stiff non-cuffed catheters have started causing thrombosis. Maybe it's either the injury while inserting the catheter or while handling or whatever may be the cause. So we have now started seeing a lot of cases where femoral stenosis or the iliac vein stenosis are. See, this catheter is too short. It will probably at the most go up to the external iliac vein, maybe. So there is a chance of stenosis. So ideally we should not keep this catheter for 7 days. Maximum, if you have a problem, up to 10 days. I would otherwise recite this catheter.
Because as far as infection goes, you didn't see, we didn't see much difference in infection rate
No.
compared to
Yeah.
in jugular
No,
catheters.
but the problem is not in the keeping the duration of the catheter. Problem is the stiffness of the catheter, the material, which causes the stenosis.
Thank you.
Your question, ma'am, and the last one from Professor Sharma after that. Yeah, please go ahead.
Sir, how do we choose the right size of the catheter for the patient? Sometimes a patient may be of small build, for example, 40 kg female. Another patient may be a 70 kg or 80 kg bulky male. In case of right internal jugular, it is still easy, but how to choose the right size in case of left internal jugular or other atypical sites, depending on size or weight of the patient?
So what we do is we mark the space between fourth and fifth intercostal space, and from there to the puncture site, which we try to go as low as possible, unlike your temporary non-cuff catheter where we try to puncture higher up. So we measure that length and then expected site of exit. So this is measured on the previous day, and depending upon the size of the patient, we choose whether it's a 19 centimeter insertion length which will be adequate or patient will need 20. Most of the Indian patients, average size, average height Indian patient, 36 centimeter of the catheter with a 19 centimeter insertion length will suffice. On the left hand side, for an average height patient, one would probably need a 40 centimeter catheter because it is going to take a longer course and it is going to involve two curves. One when you come from left IJV onto the left brachiocephalic vein, and the other one when you come from the left brachiocephalic vein and go into the SVC. So that's going to take a long curve. So again, majority of the patients will need 40 centimeter for a left IJV. However, for a short 40 kg person, even left IJV 36 centimeter catheters have been found to be sufficient. So you'll have to measure the length, expected, you do a surface marking, draw your line, measure actually, and then roughly choose the size of the catheter.
See, femoral cannulation, you must be remembering when we were in training,
Yes.
and even today, like I would accept that even at our center where we have a vascular lab available 24 hours with fluoroscopy and 4 ultrasound, the residents, when they have to do acute dialysis, they are more in favor of doing femoral punctures. And they do femoral punctures without ultrasound guidance. I tell them, please use an ultrasound guidance. The femoral cannulation without ultrasound guidance in obese patients produces a lot of problems in terms of the hematomas. The point I was trying to make that if we can use this femoral access as a temporary access till the fistula becomes mature, at least for patients who are not very ambulatory, the problem which we are facing with the internal jugular cannulation in terms of the stenosis may be much less, because fistula has to be created in the upper limb, and I don't know what is the experience in terms of the femoral cannulation long term in terms of the stenosis, whether there is any data available. The second point I would like to make, all these interventions, whether it is endovascular, ultrasound or surgical, or whether it is different access interventions for managing these patients, are complementary. The one thing which we forget, unfortunately, people who are for vascular access management, they are not in the area of peritoneal dialysis. So there are some patients at least who have difficult vascular access, they would be better managed with PD. And unfortunately, many of these patients are also not willing for PD. I have some patients who have all these accesses which are gone. We try to counsel them for PD, but they just refuse. But some of us who are so much tuned for interventional nephrology, we are much more for hemodialysis rather than PD. So I think we should also try to bring in appropriately where they could be shifted to PD.
I entirely agree with you. PD is something which is overlooked in this era of interventional nephrology, but PD should be considered as a viable option. And coming back to your first comment about this femoral ultrasound guided should be ideally performed, because especially in obese patient, actually instead of puncturing the femoral vein, you end up puncturing the saphenous vein. Then you are going to have flow problems even through femoral. Only thing is, it's question of getting oriented to, because femoral vein, femoral artery, I mean what we taught van, medial to lateral, that's all theory, but when you actually try to see femoral vein on the ultrasound in both short and long axis views, you need to get used to the orientation of the femoral vein, and I'm sure you can puncture the femoral vein ultrasound guided.
Yeah.
Dr. Hemant, last question. You had a slide of interventions where you had done 10 lumbar and 10 hepatic. What were the complications that you encountered in those cases?
When we did our first translumbar case, patient collapsed after few hours, and when we investigated, she was found to have some intraperitoneal bleed, which was from some artery which was not related to the catheter which we had put. So we don't know really what happened. Subsequently, all our punctures were successful.
So I haven't seen any hepatic cases, but I've been reading about them. And apparently there's lots of complications. Did you encounter in that?
No, for transfemoral, no complications.
Transhepatic.
Transhepatic we have not done. Because the rate of thrombosis through transhepatic is very high. But as I said, we started with translumbar, we went on to transfemoral, went on to the EJV. Now we have learned this technique of cannulating the collateral veins, dilated collateral. So I think then
for
patient comfort wise it's the best.
Dr. Mehta, I'm getting signals. I think for paucity of time, we have to move on. Thank you once again on behalf of everyone here, and thank you once again.